This is Dr. Nicholas Tedesco, DO, Associate Program Director of Good Samaritan Regional Medical Center Orthopedic Surgery Residency. Today I'm going to be presenting on cystic and lytic lesions in the orthopedic oncology realm. This is going to include both bone and soft tissue cystic lesions. As usual, I do have a disclosure that I own stock in a small orthopedic rehabilitation company, but it has nothing to do with this talk or any others. So we'll start with bone, and then we'll move on to soft tissue in the second half of the presentation. And as usual, we'll start off with malignancies and progress our way to benign entities. So the first lytic or cystic lesion of bone is multiple myeloma. It is the most common primary bone malignancy, and it's a monoclonal proliferation disorder of plasma cells, which are a B-cell lineage. Workup typically includes a skeletal survey, and that's because bone scan is usually negative because it's a purely lytic response in the bone. Bone scan only will light up positive when there is an osteoblastic or reparative response as a result of the underlying disease process, because the technetium is specific to osteoblasts. When it's pure osteoclastic activity or tumor activity, it will not light up, and so you may get a false negative bone scan with this particular disorder. You will also need a bone marrow aspiration and an SPEP and UPEP during workup, as well as a beta-2 microglobulin level for staging. CBC often shows anemia from bone marrow infiltration and myelosuppression, and then CMP will usually show hypercalcemia because of the bone destruction. Imaging typically demonstrates the classic punched out or moth-eaten purely lytic lesions with sharp margins without a reactive or sclerotic border or periosteal reaction. Vertebral plana is very common in this disease, from severe compression fracture when there's diffuse infiltration of a vertebral body with subsequent structural collapse. Here's an example of that in the left femur, where you have these classic lytic punched out lesions scattered throughout the visible femur, but portions that also appear to be moth-eaten. Then on the right image, you have complete vertebral plana of the L1 vertebra from complete collapse and infiltration of the tumor. You can also see a large tumor focus in the L3 vertebral body. On CT scan, you'll see something very similar to the X-ray, where you have these discrete areas of punched out bone where the trabeculae and the intramedullary contents are gone. You may see endosteoscalloping or complete cortical erosion as it grows and continues to encroach on the cortex. Histology demonstrates typically small blue cells with eosinophilic cytoplasm and eccentric nuclei with clumped, what they call wagon wheel or clock face chromatin. There's always cytoplasmic perinuclear clearing and extensive microvascularity, which is a hallmark of this disease as well. A peripheral smear on a blood draw will show the red blood cell rouleau formation, or stacked coins, where they all seem to line up and stack up. Treatment is a combination of chemotherapy and bisphosphonates, as well as possible bone marrow transplant. Fixation or resection, including total joint arthroplasty if periarticular, depends on the extent of impending or actual pathologic fracture, as well as the anatomic location of it. Here's that classic histologic presentation where you see these round cells with eccentric nuclei. You see the eosinophilic cytoplasm, but directly adjacent to every nuclei you can see this lunar lighter pink cytoplasmic clearing, where the darker pink is then pushed out to the periphery. You also see the wagon wheel or clock face type of clumped chromatin within the nuclei that lines the periphery in these small round nodules reminiscent of the numbers on a clock. Giant cell tumor of bone is a locally aggressive but benign neoplasm that causes local destruction but rarely can be malignant and have metastases to lungs. Most common sites are around the knee, in the distal femur and proximal tibia, as well as the distal radius, proximal humerus, and the pelvis. Imaging typically shows an eccentric epiphyseal/metaphyseal lesion that does efface the subchondral bone and crosses the physeal scar. It usually has well-defined margins with or without a sclerotic rim. It tends to be very heterogeneous on MRI, T2 stir, with dark areas representing hemosiderin deposition, and may show intense surrounding edema depending on the degree of reaction from the bone or soft tissue. Cystic degeneration is common, and it's one of the most common tumors that develops a secondary aneurysmal bone cyst. Here are imaging examples with the X-ray in the upper left corner, where you have this lytic but discrete multilobular lesion with some septae within it in the periacetabular region and extending down into the ischium with widening of the bone and an abnormal appearance. Then when you get advanced imaging with the CT scan, you see this purely lytic disease with no matrix formation within it, but significant expansion of the bone, destruction of the bone, and a large soft tissue mass extension that was not otherwise appreciated on the X-ray. MRI demonstrates the multilobular nature of this with the very low signal intensity on the T1 image on the left, but very bright signal intensity on the T2 with those darker areas in the supraacetabular region likely corresponding to the actual tumor and hemosiderin deposition, whereas the majority of the brighter region corresponds likely to cystic change within the bone secondarily. There's also a second focus of disease in this particular patient down into the upper femur. Histology will demonstrate multinucleated giant cells with nuclei clustered centrally with abundant eosinophilic cytoplasm in a bed of hypervascular, mononuclear, ovoid, and spindle stromal cells with variable mitotic activity and atypia, with or without hemosiderin deposition that will show up as a brown pigment change on the histology. The background stromal cells typically have an identical appearing nucleus to those seen in the multinucleated giant cells. These stain CD68 positive, which is a marker of histiocytic lineage, but it's not necessarily specific to this tumor. It's vimentin positive and alpha-1 antitrypsin antibody positive. Treatment typically involves intralesional curettage and extension of the margins with a burr and an adjuvant expander such as phenol, argon, cryosurgery, etc. The role of denosumab is still very unclear in this tumor. Currently it's used as a potential adjunct to surgery or as primary and definitive treatment in difficult or impossible to resect cases. Cases where the bone destruction is unsalvageable or you have severe periarticular disease with collapse, then wide resection with endoprosthetic replacement is the standard of care. Here's that classic histology that demonstrates, again, all of these scattered large multinucleated giant cells with, you can see some of these probably have upwards of 50 nuclei within them, but in the background you can't really tell the difference between the nuclei that are scattered throughout there and the nuclei within the giant cells themselves. So this helps give away the diagnosis of this particular tumor. Here's an example of a patient treated with denosumab primarily and definitively because of an unresectable tumor. This was one that extended all the way up to her ipsilateral ribs, and you can see the complete destructive changes and morphologic changes of the entire hemipelvis and hip joint. The first image is at initial presentation, and the second image is after 24 months of denosumab therapy. You can see the lesion has been stabilized in terms of size and progression, and there is significantly increased sclerosis present throughout the lesion as the destruction of the bone is inhibited by the anti-rank ligand inhibitor of denosumab. Aneurysmal bone cyst is another cystic and lytic lesion of bone that tends to be expansile. It's benign. The question is whether it's a true tumor itself versus a reactive process, and it involves hemorrhagic tissue arising in the bone. It has an unknown etiology but can arise secondary to other pathologic processes in up to 30% of these, and as we talked about, giant cell tumor of bone is one of the most common. Chondroblastoma is another one, and many sarcomas can do this as well. In the primary disease, the age is typically less than age 20, and they tend to be metaphyseal. Imaging will demonstrate asymmetric, eccentric, subperiosteal, or central radiolucent metaphyseal lesion, often wider than the neighboring physis in terms of expansion of the bone, with a very thin shell of cortical bone and multiple septations throughout it. An MRI will show thin fiber septae with multiple fluid levels throughout the lesion. Here's a classic X-ray where you have the distal radial physeal plate directly abutting this large lytic lesion with multiple septations. You have expansion of the bone, yet still a very thin cortical rim, and you can see the expansion of the bone in both planes is wider than the neighboring physis. Here's an MRI demonstrating the multiloculations of this particular disease with multiple fluid levels scattered throughout it, but all fluid within there and no obvious evidence of nodular tissue that would indicate a tumor otherwise. Histology will demonstrate multiple blood-filled cavities with multiple septae and vascular channels with no epithelial lining, with multinucleated giant cells, or, quote, pigs at the trough, surrounding these lytic areas and hemorrhagic areas. This will all be within a fibrohistiocytic background stroma that demonstrates no atypia. You can have osteoid production in this, which can add to diagnostic confusion with telangiectatic osteosarcoma. However, there's lack of a high-grade spindle cell stroma background, and the background demonstrates no atypia in this disease. There is a translocation identified of 16-17 in 69% of primary aneurysmal bone cysts. That's non-existent in secondary aneurysmal bone cysts to other processes, which again begs the question of, is this a reactive phenomena in some particular cases? Treatment is typically curettage with high-speed burring and a local adjuvant with or without polymethyl methacrylate, or bone grafting of the cavity, again depending on the anatomic location and degree of structural damage of the surrounding bone. Some primary aneurysmal bone cysts can now be treated as well with percutaneous doxycycline injections. However, these require a trained interventional radiology team that has to get into each of those septae, which can involve multiple injections. It also involves typically serial injections over the course of a year, so it tends to be reserved for those that are difficult to resect or multiply recurrent. Doxycycline in this particular situation is used as both a sclerosing agent as well as direct toxic effect on these cyst-forming elements. Here's an example of low-powered microscopy of an aneurysmal bone cyst, where you see those thin fibrous septae with these giant lakes of hemorrhagic tissue. You can also see a lot of scattered giant cells throughout there. Those are those darker, purpler, larger cells scattered in that septae around these lesions. As we zoom in, here's that example of the spindle cell background without significant atypia. A lot of the cells are relatively homogeneous. There's also a lot of fibrous tissue between the cells rather than wall-to-wall pleomorphic cells typically seen in telangiectatic osteosarcoma. Here you see those multinucleated giant cells, and they tend to be clustered around these islands of hemorrhagic tissue without an epithelial lining. A unicameral bone cyst is a fluid-filled cyst within the bone and not a true neoplasm. These are thought to be the result of local venous congestion causing extravasation of an ultrafiltrate of plasma, leading to the fluid collection, which causes the bony lysis and allows these to continue to propagate. These tend to be almost exclusive to skeletally immature patients with few exceptions, and often regress with skeletal maturity. Location tends to be metaphyseal. It tends to be in long bones, and most commonly in the proximal femur and the proximal humerus. As the child grows, these tend to become more diaphyseal as they go along. On imaging, there will be a lytic and expansile lesion centrally located within the metaphysis with very thin scalloped cortex, but not multiple septations. There's usually just a single cavity, and these tend not to be as wide as the neighboring physis, unlike an aneurysmal bone cyst. If they fracture, you can have a fallen leaf sign, which is a fallen cortical fragment in the bottom of the lesion or floating in the middle of the lesion on the fluid-blood barrier from the active fracture and hemorrhagic tissue. These tend to be very homogeneous on MRI with a single fluid barrier, if any. Here's an X-ray example on the left side in the proximal humerus, where you can see this lytic expansile lesion with a pathologic fracture and very thin cortex, but you don't see nearly as many septations as you do on the aneurysmal bone cyst example we just showed, and you can see this is roughly the width of the neighboring physis as opposed to significantly larger. An MRI of the proximal femur is seen on the right, where you have a single fluid-filled cavity with one fluid level. On histology, you'll see a thin fibroblastic spindle cell membrane surrounding the cystic cavity with scattered inflammatory and giant cells and no atypia. The surrounding bone is non-reactive, and the fluid contains high levels of prostaglandins, which again may be one of the things driving the formation of this. Treatment is typically observation if it's the lesion alone that was found incidentally, or if they're having some antecedent pain. However, many of these present with pathologic fracture. The typical treatment is you treat the fracture like any other fracture in this particular area in the child, and you allow the fracture to heal first. That's because as the fracture heals, typically it will resolve these unicameral bone cysts. Sometimes it does not, and so if they have recurrent pain or a second fracture, then we'll typically offer treatment. Likewise, if they truly have an impending fracture and significant dysfunction as a result, then you can talk about intervention even before they fracture. The treatment can be an open curettage with bone grafting versus a percutaneous aspiration and injection of bone graft, such as injectable demineralized matrix or methylprednisolone. Here's that histologic example where you see normal mature bone at the periphery of this that's non-reactive. You don't see new bone formation or osteoid production. You see this thin fibrous membrane overlying the top of that with the empty cavitary space above it. Eosinophilic granuloma is our next disease. It's a benign tumor of Langerhans type histiocytes. It's known as the great imitator due to variable clinical and radiographic appearance consistent with many other bone tumors and infections. It mimics so many that I typically train my residents that whenever you see anything in the bone, no matter what your differential diagnosis is, throw eosinophilic granuloma onto the end of that list. Presentation typically ranges from an asymptomatic lesion that's picked up incidentally to severe pain in that area, to systemic symptoms, including fevers as well as anemia, thrombocytopenia, recurrent infections, especially if there's extensive bone marrow involvement. Usually when you see that, it's one of these two diseases, Hand-Schuller-Christian or Apt-Lederer-Siwi. Hand-Schuller-Christian disease is a polyostotic eosinophilic granuloma with exophthalmos from deposits behind the eyes, as well as central diabetes insipidus from pituitary involvement, with or without other pituitary deficiencies and or visceral involvement. These tend to be disseminated diseases that need chemotherapy in addition to potential local treatments depending on the degree of structural damage. Apt-Lederer-Siwi disease is a widely disseminated disease. It's autosomal recessive and it involves hepatosplenomegaly and extensive bone and organ involvement that typically is fatal before age 3. Here's an example of a 3-year-old child that presented with one of these. His clinical background was just a limp when he was playing that his parents noticed that wasn't going away. X-rays were taken that do reveal a lytic lesion in the right ilium, but could easily be missed with the presence of all the bowel gas around it. So further workup was taken with a CT scan that now confirms a lytic and destructive process with no matrix formation centrally. However, one of the hallmarks of this disease is that when you see that lytic and destructive process in the presence of an aggressive tumor like Ewing's sarcoma, especially in this age bracket, you'll typically see a large soft tissue mass extension, whereas with eosinophilic granuloma, you almost never see it extend beyond the bone. So even with those destructive changes and appearance of cortical breakthrough on the CT scan, on the MRI, you won't see any disease outside the bone with very few exceptions or only a very small amount of eccentric disease pushed outside the bone. So here is his MRI with the T1 up top, T2 in the middle, and T1 post-contrast image on the right. Here's where you see that lesion. It's heterogeneous. It's confined to the medullary cavity with no extension beyond, but you do see this reactive, angry, infiltrative edema pattern surrounding the bone, which is part of the pain driver in this particular disease. However, that's not tumor that's enhancing outside the bone, but rather inflammation, because you don't see a discrete enhancement pattern. Instead, you see this more feathery infiltrative pattern within the native muscle. On histology, you'll see Langerhans type histiocytes, which have kidney bean-shaped nuclei with intracytoplasmic Burbeck granules, which are tennis racket-shaped inclusions bodies that are only seen on electron microscopy, with an unknown function. These are all mixed within a background of eosinophils and inflammatory cells, which is where they get the name eosinophilic granuloma. Langerhans cell histiocytosis is probably the more correct term for this particular disease. Langerhans cells are S100 positive, CD1A positive, which is pathognomonic for this disease, and Langerin, which is CD207 positive. So if you see a lesion that has inflammatory cells, eosinophils, kidney bean-shaped nuclei, and a CD1 alpha positive stain, it's eosinophilic granuloma. There's nothing else it could be. Treatment is observation because most of these will resolve spontaneously, especially when they're monostotic in the children as they grow. However, if it is significantly painful or they have a pathologic fracture, you can do a CT-guided intralesional injection of methylprednisolone or an open curettage with or without a concomitant intralesional injection of methylprednisolone once again. You may need bracing or radiation for spinal lesions with cord compromise. Otherwise, even vertebra plana often requires no treatment. Chemotherapy is needed, as we mentioned before, for Hahn-Schüller-Christian and Apt-Lederer Seaweed disease because of the wide dissemination of it. Here is that histologic example where you see a lot of kidney bean-shaped nuclei within this area. However, you see a lot of large cells with kidney bean-shaped nuclei. These are the Langerhans cell histiocytes. However, in the background, you see all these bilobed or trilobed red-colored cells. These are all the eosinophils that are scattered throughout this. And so when you see all of these eosinophils with these larger histiocytes with pink eosinophilic cytoplasm, you should be thinking eosinophilic granuloma. Hopefully they'll give you that CD1A or CD207 stain that then helps put the nail in the coffin. Here's an example of those Birbeck granules on electron microscopy. You can see the tennis racket shape where you have these cross striations in the handle of the racket and then the large open area at the end. Again, it's unclear what these are in the cells for or what their derivation is. Erdheim-Chester disease is basically the same exact thing with same presentation, except it's non-Langerhans cell histiocytosis. It has similar histology, similar treatment, all of that stuff, but this one tends to be in older adults. So whereas children tend to get Langerhans cell histiocytosis, adults tend to get Erdheim-Chester disease. Histology will show histiocytes, but they will stain negative for the Langerhans lineage, like the CD1 alpha and the CD207. But they will typically be CD68 positive, which is the histiocytic lineage stain. Brody's abscess is another cystic lesion of bone. It's a subacute smoldering osteomyelitis, with Staphylococcus aureus being the most common. This may persist for years before becoming a frank and aggressive acute osteomyelitis. Imaging will usually demonstrate an oval or elliptical or occasionally serpiginous radiolucency, but usually greater than a centimeter and surrounded by a heavily reactive sclerotic margin with or without scalloped borders. MRI will usually show surrounding edema, and the lesion will be homogeneous but low signal intensity on T1, bright on T2 with peripheral enhancement post-gadolinium because it's not live cells, it's just an abscess. These tend to be seen in children or young adults, and they can be epiphyseal or metaphyseal most commonly. Here's an X-ray example of an epiphyseal lesion in a young child. You can see this lytic lesion with a thin rim of sclerotic surrounding bone on both the AP and lateral view. When we go to the MRI, the T1's on the left, T2 in the middle, and T1 post-contrast image on the right. So on the T1, that lesion is homogeneous and low signal intensity, and on the T2, it's very bright, and you can see the surrounding edema within the epiphyseal bone there. On the T1 and T2, you see that dark rim surrounding this area, and that's indicative of the sclerotic increased calcium deposition. You also see on the T2 that this bubbles into the cartilaginous portion of the epiphysis. So this is a somewhat of an aggressive process. However, on the fat-saturated T1 post-contrast image, you see peripheral enhancement of this without central enhancement. That's that dark area in the middle. That's indicative of a cystic lesion as opposed to a tumor. The differential diagnosis, especially based on the age here, would include chondroblastoma, but chondroblastoma will enhance because it's live, active neoplastic tissue. Histology will show an inflammatory infiltrate with or without a positive gram stain. Treatment is usually open biopsy or percutaneous drainage with interventional radiology, followed by 6 to 8 weeks of IV antibiotics, just like any other osteomyelitis. However, in some children, there is some evidence to support oral antibiotics and for as short as 4 weeks. Consider empirically treating for Staphylococcus until cultures return positive. Otherwise, if it's very large, or open biopsy is warranted, and aggressive open irrigation and debridement can be done, especially if it's recurrent after appropriate treatment otherwise. A geode, another name for this, is an intraosseous ganglion, and it's often asymptomatic unless it's due to degenerative joint disease or it's large enough to be structurally problematic. Imaging will show a juxta-articular, eccentric, oval, geographic, purely lytic lesion with or without surrounding sclerosis, but the MRI will show the exact same as a soft tissue ganglion. Very homogeneous, fluid-filled, low signal intensity on T1, very bright on T2, with peripheral enhancement, post-contrast, with or without joint communication, again, if it's related to degenerative changes. Treatment is typically observation versus a curettage with bone grafting if there is any significant structural damage or impending or actual pathologic fracture through it. On X-ray, for a geode, you'll see this purely lytic process with or without cortical expansion. You see it juxta-articular. You also see that very thin rim of sclerotic bone surrounding this. Looks very similar actually to a Brody's abscess. On CT scan, you do see that direct communication with the joint right at the shoulder of the mortise, but again, you see a purely lytic process, geographic thin rim of sclerotic reactive bone, and no matrix formation within the central portion of the lesion. You can see this lesion within the distal tibia that's homogeneous and low signal intensity on T1, but very bright on T2. There's a small amount of surrounding edema, which is why this presented with pain, probably due to structural compromise of the medial malleolus. So this is one that may be amenable to curettage and bone grafting. You can see this thin black rim surrounding this on the MRI. That's also indicative of the sclerotic rim of reactive bone. Next is a brown tumor or osteitis fibrosa cystica. This is fibrous replacement of and cystic dilation, which is the brown tumor, in bone due to overreactive osteoclastic resorption seen in hyperparathyroidism. So a brown tumor is part of the overall spectrum of the disease. This typically presents with the stones, bones, moans, and psychiatric overtones of hypercalcemia, which includes renal calculi, bone pain or osteopenia, constipation, and lethargy. Labs will have a high calcium level, high parathormone, and high alkaline phosphatase. On imaging, you'll see diffuse osteopenia with well-circumscribed but lytic, expansile, and septated regions representing the brown tumors. These can look very aggressive or very much like an aneurysmal bone cyst. Treatment is simply correction of the increased parathyroid hormone via removal of an adenoma and primary hyperparathyroidism, or correction of the renal failure issues with dialysis, phosphate restriction, and vitamin D replacement or kidney transplantation in secondary hyperparathyroidism. The tumors tend to resolve once the parathormone is normalized and the bone has a chance to respond to the changes. You can perform fixation of impending or actual pathologic fractures as indicated, again depending on where they are and how destructive they are. Here's an example in the clavicle of a young male who presented with pain and expansion of his clavicle. Again, you can see the multiple septations, the significant expansion and lysis, and it looks like a very aggressive process. CT scan demonstrates the same, with what appears to be matrix formation within the central portion of the lesion, but that's actually just remnants of the native host bone that this is infiltrating. On histology, you'll see osteoclastic resorption and fibrous marrow replacement that produces a small hole that becomes confluent with others to create a large brown tumor consisting of clustered giant cells around minimal bone and fibrous cellular stroma with or without hemosiderin. It must be differentiated from giant cell tumors because it looks similar on X-ray, gross pathology, and histology, and so it must be ruled out with labs by getting the alkaline phosphatase, the calcium level, and the parathyroid hormone level. So here is that example where you have all of these multinucleated giant cells, background stromal cells, but a lot of hemosiderin deposition, which is all that brownish pigment deposited all throughout this. But again, this can be confused easily with a stereotypical giant cell tumor of bone, so you have to get those labs. You can also see in the background the pinkish areas that represent the fibrotic changes within the bone marrow. That concludes bone, and so now we'll move on to the soft tissue cystic lesions. First one is a ganglion cyst. Presentation is typically a mass with or without pain. It typically transilluminates on an exam, which means it allows light to pass through it because there's no solid component that will block the light. On imaging, the MRI with contrast is the test of choice because it will show a multiloculated homogeneous lesion that is very bright on T2, very dark on T1, often near joints, and then will have a very thin rim of enhancement post-gadolinium. Treatment is observation. You can also try an aspiration with cortisone injection versus resection versus correction of the underlying joint pathology if it's reactive, so chondroplasty, osteophytectomy, etc. Here's an MRI T1 example of a mass overlying the gastrocnemius muscle near the popliteal fossa, and you can see a very homogeneous dark pattern on the T1 and very homogeneous bright signal on the T2, indicative of a ganglion. Again, in order to differentiate this from a benign myxoma, would be a gadolinium contrast image that will show thin peripheral enhancement in a ganglion and wispy variable enhancement of the gadolinium intralesionally for the myxoma. A Tarlov cyst is a fluid-filled nerve root cyst found most commonly at the sacral level of the spine. Spinal nerve root fibers are found within the cyst wall or within the cyst cavity itself. Presentation is usually found incidentally, but they may have a remote history of trauma to the region. Most often symptomatic, but rarely can cause radicular pain, paresthesias, and urinary or bowel dysfunction, depending on the nerve roots affected. These are just like any other cysts, where they're homogeneous and low signal intensity on T1, bright on T2, with a thin peripheral enhancement post-contrast if given, but usually these are incidental findings. Here's an example in that left sacral foramen, this large homogeneous lesion, and then on the sagittal you can see it's multi-lobed, but again very homogeneous and very bright signal on T2. Histology will usually show a CSF-filled cyst containing nerve roots within the cyst cavity or within its wall. Treatment is typically medical with diuretics that may help decrease the cyst size, NSAIDs, heat, ice, or activity modification. Surgical is reserved only for symptomatic patients and or bowel or bladder dysfunction. You can attempt a CT-guided needle aspiration as well as an injection of fibrin or a sclerosing agent. You can perform a decompressive laminectomy, a cyst or nerve root excision, or microsurgical cyst fenestration and imbrication or overlapping of the cyst wall so as to close it. To decrease the risk of CSF leak following surgery, the patient is usually advised to stay in bed with the foot of the bed raised and to wear a corset to control swelling until it has a chance to scar closed. Hematomas and seromas are the next cystic lesions of soft tissue. They are either a collection of blood, which is the hematoma and hemorrhage, or plasma and serum filtrate, which is a seroma. They're often associated with trauma and or surgery, and imaging may show calcification on the x-ray, especially if they're long-standing. It's usually dystrophic calcification as opposed to heterotopic ossification. On a hematoma, the MRI will show a feathery, long on sagittal and coronal cuts and narrow on axial cuts lesion with an infiltrative appearing heterogeneous mass with no central contrast enhancement that is confined to one muscle or intermuscular plane. CT will also show the feathery, long on sagittal and coronal cuts and narrow on axial cuts, infiltrative appearing heterogeneous mass. A seroma, the MRI will usually show a single fluid level of the large cystic component of it. Here's an example of a periosteal hematoma where you get subtle elevation of the periosteum with a thin reactive sclerotic appearance, but a lytic portion deep to that that's indicative of the space being filled by the hemorrhagic tissue. Here's a more advanced one on the right side where you see a larger region of calcium being deposited, and this is actually within muscular plane from a long-standing old hematoma. On MRI, you'll see low signal intensity on the T1, bright on the T2, and peripheral enhancement post-gadolinium. Again, you see that lack of round discrete mass, you see the feathery infiltrative borders, you see the heterogeneity that can help rule out sarcoma in these particular instances. Longitudinal MRI, now you see it much larger, as we said before, where it will be narrower on the axial cuts and much larger on the coronal and sagittal cuts where it infiltrates a muscular plane, but again, it's not a discrete mass that's pushing tissue away as opposed to a more infiltrative process within the tissue plane itself. CT scan shows, again, now a more discrete process, but still with these feathery and infiltrative and spiculated borders as opposed to a discrete outlineable mass like is typically seen in sarcoma. The differential diagnosis here could be an aggressive fibromatosis or desmoid tumor, but this is where history helps and possibly biopsy if indicated. Here's a postoperative seroma. This was an MRI taken for a patient who had a sarcoma resected here with concern for recurrence when a palpable mass was noted. However, you notice that large single fluid level indicative of simple postoperative seroma. Treatment is aspiration or evacuation for large lesions, impending skin compromise, or Morel-Lavalier lesions. You want to always send an aspirate or tissue for cytology and biopsy in low or non-traumatic cases, as sarcomas are frequently misdiagnosed as hematomas. So if you end up in there and you're not sure why or how this happened, then definitely perform an open biopsy using appropriate oncologic techniques. An ancient hematoma or chronic expanding hematoma is a long-standing, months to out to even decades, deep-seated, often enlarging mass that mimics a tumor. So these ones, for all intents and purposes, completely mimic a sarcoma and should be dealt with very carefully in case they are, and usually it's going to be an open biopsy or procedure that will give you the diagnosis that it's actually just an ancient hematoma as opposed to a sarcoma. Diabetic myonecrosis is a spontaneous myonecrosis from infarction of the muscle in the setting of chronic uncontrolled type 1 or 2 diabetes mellitus or in the setting of diabetic ketoacidosis. They can be secondarily seeded by hematogenous infection, and they may stem from hypoxia reperfusion injury, atherosclerotic occlusion, atheroembolism, or vasculitis with thrombosis. Presentation is typically acute or insidious over several months, onset of pain, swelling, warmth, erythema, and even refusal to use the limb because of pain. White blood cell count, ESR, CRP, and CPK are often elevated, so it mimics infection and sarcoma. Both must be ruled out. Imaging, CT scan with contrast will demonstrate soft tissue swelling and edema with large areas of necrosis. MRI will show a low signal on T1 that is feathery and infiltrative and involves one or a group of muscles without discrete mass formation. There's a high signal intensity on T2 because of the inflammation and large contrast voids in necrotic tissue post-gadolinium. Treatment, it's self-limiting, so symptomatic control is usually all that is needed. You can do a CT-guided or surgical drainage of the fluid pockets if infection is suspected or confirmed. Here's a CT scan with contrast showing this large mass within the gluteal tissues overlying the hip, and you can see those focal areas of necrosis within the middle portion that do not enhance. On MRI, you see the low signal intensity on T1 on the left, bright signal intensity with feathery infiltrative borders and no discrete mass. Rather, it's hyperintensity of the muscular and reactive tissue on the right, and then the post-contrast image down below demonstrates the peripheral enhancement with central necrotic area, and the enhancement is of that inflammatory component. Here's an AP that demonstrates the same of a post-contrast imaging that again shows those necrotic regions in the center and the infiltrative reactive tissue enhancing within the gluteal musculature without discrete mass formation. Finally, we'll end with an abscess. Some of these can be very large and can mimic tumors, especially in the setting of immunocompromise. The big thing to know about these is if you are working them up with respect to tumor where maybe there's not a typical painful reaction, erythema, induration, or inflammation because they're immunosuppressed and they're massive, you end up getting an MRI to rule out sarcoma, and what you will see is a lesion that's iso-intense to bright on T1 compared to skeletal muscle. It may not be as bright as subcutaneous fat, but it will be brighter than skeletal muscle, and it will also be bright on T2 with peripheral enhancement, with or without surrounding edema and myositis post-contrast. Here's an MRI example with a standard T1 on the left where you see this very bright lesion. Then you see the fat-saturated T1 on the right where the fat suppressed but the lesion did not, so you know it's not a fatty tumor. Then you get the T2 on the left that continues to show a very bright signal intensity indicative of the fluid component of this large abscess. And then the post-contrast shows very thin peripheral enhancement with mostly central necrosis. And this ended up actually being a fungal abscess in an immunocompromised patient where, again, you see this very large mass, but no real surrounding reactive tissue in the muscle or anything like that where his immune system is just not mounting a response to it. So I'll leave you with my Pacific Northwest Pride slide. This is Silver Falls outside of Salem, and you can see all those tiny little white specks in the middle of that waterfall are all the people. So this is actually a pretty large and long falls, and it's beautiful. And there's a couple other in this creek system, so it's a really cool hike if you get an opportunity. It's only about an hour from Corvallis. So thanks for listening, and again, call, text, or email at any time with any questions.